Hi everyone, welcome back to our channel Human Anatomy by Doctor Ankit, and we are into this MCQ series. Today is the we can say the last video for the lower limb session, and then we'll move to the other topic, that is neuroanatomy. So without wasting any further time, let's start the session over here. So yes, here is the first question of the day, and the question asks that a 6-year-old boy is playing barefooted steps on a piece of broken glass and suffers a large transverse cut on his sole at the level of the midfoot. In the emergency room, the examining physician determines that the cut is to the depth of the first layer of the plantar muscles. Which of the following structure is most likely damaged? So in this particular question, we have to actually identify that there is a cut in the plantar muscle layers, and there is a cut to which layer? To the first layer. How many total layers are there in the sole of foot? There are total 4 layers. Right. So what are the contents of the first layer to begin with? First layer over here will have few muscles. Like what? The easiest way to remember it, and I have told previously also, is I'm making a hand symbol like this over here. Right. What is this? I have abducted my little finger, I have abducted my thumb, and the other fingers are flexed. So imagine it is a foot, and these are the toes. This is the great toe, that is, or the subsequent toes. So if you do this, you are abducting the great toe abductor hallucis, you are abducting the little toe abductor digiti minimi, and you are flexing the other fingers or the toes, flexor digitorum. Right. So the muscles in the first layer will be our abductor hallucis, then we will have abductor digiti minimi, and we also have the other flexors, flexor digitorum. Right, not the longest but the bravest one. Why? Because the longest is found in other layer. You will discuss them in the second layer. So these are the 3 muscle layers or 3 muscles in the first layer. So if you try to identify the answer over there, answer becomes very specific, abductor hallucis muscle. Now if tomorrow they ask you, okay, we know the muscle, tell me about the nerve supply. Then remember that the only 2 nerves which are present in the sole of foot are either the medial or it is the lateral plantar nerves. So medial or lateral plantar nerves, and both of them are branches of which nerve? Both of them are branches actually of the tibial nerve, remember that. Now hallux being on the medial side, or the great toe being on the medial side, it is contrast to the thumb in the hand, that is on the lateral side. So if it is on the medial side, it is mainly supplied by which nerve? It is supplied by the medial plantar nerve. Right. So here we can see the other muscles, or the muscles in the first layer. What we will see over here is this, the abductor hallucis, that is abductor digiti minimi, and the third muscle over here is the flexor digitorum muscle over here. Okay, these are the first layers. Just to recap over here, so that we have some information, we have the second layer also, we have the third layer also, we have the fourth layer also. Now can we make out any way by which we can easily remember the name of the muscles over here? I think we can, right? So how? In the second layer, what we have is the 2 long tendons, not the muscle, the 2 long tendons. And those tendons will come from the posterior leg compartment. They are the flexor hallucis longest tendon and flexor digitorum longest tendon, supplied by tibial nerve. But these are what? These are the T for tendons. So what will be the M for muscles over here? The muscles in the second layer will be the muscles which are coming from the flexor digitorum longus and are inserting into flexor digitorum longus. Those are our flexor digitorum accessorius, also known as quadratus planae, and we also have the lumbricals over here. So these are the 2 main muscles found in the second layer, right? Second layer. Coming to the third layer. Now third layer is, this is number 3 over here. This is third layer. Like you remembered the first layer, we can remember third layer. How? In the third layer, you can see that our thumb and little finger are flexed, or you can say the great toe and little toe are flexed. So we have a flexor hallucis and flexor digitorum. Plus imagine the great toe is moving towards midline, so it is also adductor hallucis. So there you go, you have 3 muscles now. The 3 muscles found in the third layer are the flexor hallucis, flexor digiti minimi, and also adductor hallucis, adductor, A-double-D, adductor hallucis. Now the fourth layer is the deepest layer, close to the metatarsals. And like in hand, we have the interossei which are attached to metacarpals. Here we will have the interossei which are attached to the metatarsals. What are those? Again the same names, plantar interossei and dorsal interossei. In the hand we call them as palmar. Instead of plantar we call it as palmar. That's the whole point. So first layer, remember this, second layer has two long tendons, third layer is this, fourth layer are the interossei. Let's see the next question over here. In this we have to identify the tarsal. On a given radiograph, the fractured tarsal bone is identified by the black arrow with accompanying impaction of the tarso-metatarsal joint. What bone articulating with the fourth and fifth metatarsal is fractured? So basically, we have to identify this bone over here, which is marked by the black arrow. In addition, they are giving you a hint that it is attached to the fourth and fifth metatarsal. So it is the fourth one, this is the fifth one. So it's a tarsal which is located on the lateral aspect. And let me show you the bones over here. The bones over here are, this is the calcaneum or calcaneus. Above calcaneus, this part is the talus which articulates with the tibia fibula forming the ankle. In front of talus, we have this N for navicular. In front of navicular, we have these bones as the cuneiforms. These are the three cuneiforms. And the labeled one now, the labeled one over here, this one is what? It is forming a joint with the calcaneum present behind, that is the cuboid bone. So this bone is a cuboid, and I am sure that has to be one of the options. Here we go. Now here is an image showing you the bones of the foot. In this image also, let us try to identify the bones, at least the tarsals. This is the talus ankle joint. This heel bone is the calcaneus. In front of calcaneus, this is the cuboid which was asked in the question. In front of talus, we have this as the navicular. And in front of navicular, we have this medial cuneiform, intermediate cuneiform, and lateral cuneiform. 7 tarsals. The metatarsals are numbered from medial to lateral because this is the greater side, first, second, third, fourth, and fifth metatarsal. Right, this is the lateral view. So this is again, I am repeating, it's a cuboid which they actually asked. And to identify this as the fifth metatarsal, how? Because it has this tubercle over here. What muscles are attached over here? That can also be asked. The muscles over here will be the everters of the foot. So basically they are the peroneus brevis and peroneus, not the longus but the peroneus tertius, because peroneus longus goes, the tendon of the longus goes onto the plantar aspect and then it goes attaches to the medial side. Okay, so remember that point. Lateral view and medial view as well. Again over here, navicular, T for talus, this is the medial cuneiform. Okay, let's see the next one over here. A 41-year-old man is admitted to the emergency with a swollen and painful foot. Okay, radio examination reveals that the head of the talus has become displaced inferiorly, thereby causing the medial longitudinal arch of the foot to fall, causing a sort of flat foot. What would be the most likely cause in this case? So if there is an emergency because there is some accident, swollen, painful foot, but head of the talus is displaced inferiorly. What is the cause? Now look over here on the medial aspect. They are saying, let me put a blue arrow over here, that this is the head of talus. This region is the head of talus. Now they are saying that this head of talus is displaced inferiorly. So is there any structure over here which is supporting the head of talus? Yes, there is, and therefore this structure over here might be damaged or injured, which led to the head of talus going down or inferiorly. What is the structure? There is a strong ligament over here which is connecting what? Which is connecting the sustentaculum tali of the calcaneum to the navicular bone over here. And what is that known as? This one is known as what? Spring ligament. Other technical name of this will be PCNL. What is PCNL? PCNL is plantar because it is on the plantar aspect. C is calcaneo, N is a navicular, and L is a ligament. So this is PCNL, plantar calcaneonavicular ligament, also known as the spring ligament. So answer in that question over here will be the damage to the spring ligament, option number A. If we look at the option number A, tearing of the plantar calcaneonavicular ligament. If you look at the other options, cuboid bone is present where? Laterally. Now plantar aponeurosis is present throughout the the plantar aspect. Sprain of the anterior talofibular ligament, this is present again laterally because it is fibula over here. If I show an image of the ligaments over here, this is, you are looking at the medial aspect, right? Now very carefully see, this is the sustentaculum tali, and this ligament over here, if I make with some red box over here, this is our in question spring ligament or PCNL. Okay, other ligaments if you want to see, this is the medial malleolus of the tibia over here, right? So which ligament will be this? It is connecting tibia to the talus posteriorly, so we call it as posterior tibiotalar ligament. Okay, look at this ligament now. It is attaching tibia to the calcaneum, so this is tibiocalcaneal ligament. Now this ligament over here, right, where it is going? It is going from tibia to the navicular. So why navicular? Because this is the navicular bone over here. So it is tibio-navicular ligament. And lastly, if I change the color to this ligament over here, it is connecting tibia to the anterior part of talus, so it will be known as anterior tibiotalar ligament. So you've seen all the ligaments. And all of these ligaments, tibiotalar, anterior, posterior, tibiocalcaneal, tibio-navicular, these are combinedly known as the deltoid ligament. They are very tough over here. They are combinedly known as the deltoid ligament. Let me highlight this as well, so you remember it. Okay, spring ligament is not a part of deltoid ligament. It is different, and in this particular question, this was the answer. So do identify the ligaments as well. They are important because ankle sprain is quite common. The next question asks, a 22-year-old female basketball player foot is forcefully inverted. Inversion is this movement. The sole of foot is facing medially. If suppose these are the two foot, this is inversion of both the foots. And when leaving the court, after getting her ankle taped for support, she re-enters the game. Which ligament was most likely damaged? They are actually directly asking, in case of inversion injury, ankle inversion, which is the most common ligament that will be damaged? Now, if there is an inversion, then which side of the foot is getting stretched? Medial or lateral side? It is the lateral side. And lateral, which ligaments will be there? Ligaments connected to the fibula. Like what? Like we have the talofibular ligaments, having both anterior, posterior talofibular. Calcaneofibular, so you have talofibular, we have calcaneofibular, all these are present on the lateral aspect. But the most common damaged ligament or the weakest ligament in this is the anterior talofibular ATFL injury. We normally in orthopedics, we call it as an ATFL injury, anterior talofibular ligament. Let us see an image of this too on the lateral aspect. So previously we have seen on the medial aspect. Now we will be looking at the lateral aspect. Let us zoom it a bit. This is the fibula or the lateral malleolus of the ankle. Now let us start to identify few of the ligaments. This is which ligament? This is the ligament that is the one in question, anterior talofibular ligament, ATFL. Okay. Now which ligament will be this over here? PTFL, posterior talofibular ligament. Then which ligament is this? Apply common sense. It is connecting which two bones? Fibula and calcaneum. So calcaneocfl. CFL, we have CFL bulb, na? Calcaneofibular ligament, right? And what are these over here? If I ask you, no, just a second, this is not calcaneofibular, I just corrected. This is actually connecting the fibula to calcaneum, but this is not calcaneofibular, this is the calcaneofibular. Now I'm highlighting it, this one is the calcaneofibular over here. Then what was the one which we wrongly marked initially? These are the peroneal retinacula. These are the peroneal retinacula. Why? Because the tendons are passing deep to it. Peroneal retinacula. So don't confuse in exams. One is a superior, one is the inferior peroneal retinacula. There are two tendons passing deep to it. Let us see them too. This one over here and attached to the lateral tubercle of the fifth metatarsal, it is peroneus brevis. And the deeper one over here, this is the tendon of peroneus longus, right? So these are a few important ligaments. This will be a tibiofibular ligament. This is actually intraosseous tibiofibular because it is between tibia and fibula. So these are the ligaments on the lateral aspect. So don't confuse, like we have just seen over here a bit of confusion. Don't confuse the calcaneofibular with the peroneal retinaculars. Identify ATFL, identify PTFL as well, right? A 25-year-old and IV drug abuser has been injecting himself for 5 years, leaving much scar tissue over the points of vascular access. The patient is admitted to the emergency for a detoxification program requiring an IV infusion. The femoral veins in his groin are the only accessible and patent veins for IV use. Femoral vein in the groin. Remember your wards. That is why it is always advisable to go and do the ward duties in internship or in MBBS time. You must have done the femoral tapping if you have visited the wards, mainly in medicine wards. So femoral veins are the only one accessible, which is the landmark for identifying the femoral vein. Femoral vein lies medial to femoral artery. Femoral vein is in the canal. Femoral vein lies lateral to femoral artery, medial to femoral nerve, directly medial to femoral nerve. What is the answer? Remember, this is a question from the topic of femoral triangle. And if we discuss about the contents of femoral triangle, then in our lectures, earlier lectures or earlier discussion, we have seen that the contents, if you go from lateral to medial, can be easily remembered by the mnemonic navel, NAVEL, lateral to medial. What is NAVEL? N refers over here as the femoral nerve, N for nerve. A over here refers to femoral F dot artery. This is the one that is as femoral vein. E is actually an empty space, therefore it is known as femoral canal. Where L, the lymph nodes lie, the deep inguinal lymph nodes, lymph node of Cloquet or Rosenmuller. If you look at the options, femoral vein lies medial to femoral artery, perfect. Option A is perfect over here. Femoral vein is lying medial to femoral artery. And this is how you do a femoral tapping. You palpate the femoral artery. Where do we palpate it? It lies at the mid-inguinal point. And then you take your needle perpendicularly and insert it just medial to the femoral artery. And then the blood that is coming to your syringe is the venous blood. Second option is femoral vein lies within the femoral canal. Wrong. In the femoral canal, we have an empty space. The femoral vein lies lateral to femoral artery. Wrong. The femoral vein lies directly medial to femoral nerve. Option D. Now, the femoral vein lies medial to femoral nerve is correct, but not directly. Because in between nerve and vein, we have a femoral artery. Answer is option number A. Let us see an image over here. Okay, here you are seeing the femoral triangle. How to identify? You are looking at a sartorius muscle over here. This is sartorius muscle going down, right side femoral triangle. These are all the branches of the femoral nerve, as you can see over here. It lies most laterally. Then you are seeing over here, if I may write it like this, this is N for a nerve, A for artery, V for vein, nerve, artery, vein. And then middle to it, we have over here the empty space, femoral canal, which will have actually a lymph node known as the lymph node of Cloquet or Rosenmuller. It is a deep inguinal lymph node. It is a deep inguinal lymph node, remember that. Okay. A young man suffers a dislocation of the right hip in a car accident. During recovery, he finds he has an abnormal gait in which listen carefully, in which his left hip sinks when he lifts that foot to take a step. He had a dislocation of which side? Right side. But now his left hip is sinking down. So injury occurred on the right side, the left hip is sinking down. If you look at the image also, you will realize we are dealing with the Trendelenburg's gate over here, a Trendelenburg's sign over here. The problem may be the result to damage of which of the following structures. So if you see this image, as this person is putting the right foot on the ground and lifting the left foot off the ground, the left hip you can see is going down. You can see this inclined red line over here, which normally should be horizontal. This is a normal case. So what actually happened is that as the right hip joint was dislocated, here the problem of dislocation occurred. So these green colored muscles, they are not working now. These are the abductors of the hip joint, and we should be knowing their names being gluteus medius and gluteus minimus. And the nerve supply of them is, we have discussed, superior gluteal nerve. So problem is on the right side, right superior gluteal nerve. The muscles paralyzed are the right side, but as the right abductors are not able to function properly, the moment the patient takes the left foot off the ground, the left side pelvis goes down. So it is a normal side pelvis that goes down. The problem is where? The problem is on the right side. So we look at the options over here: right, left, right gluteus maximus, no, left, no. Answer is option number C, right medius and superior gluteal nerve. It is not right gluteus maximus, so we can remove this option A. Option B, option D also wrong. Why? Because it is supplied by superior, not inferior gluteal nerve. Okay, so remember this. This is a Trendelenburg's gait over here. You can see Trendelenburg's gait, inadequate pelvic stability over here. Okay, here in this case, when the right foot is taken off the ground, the right side pelvis is dropping down. Trendelenburg's gait. Okay, do remember on this side is the normal side. Okay, let's see one more question over here. 36-year-old injured in an automobile accident tells the paramedics at the scene that her upper thigh hurts badly and she can barely flex her hip. Problem in flexion of the hip. It should run to your mind directly that which is the muscle that is the main flexor of the hip. The answer comes is the iliopsoas muscle. It is a major flexor of the hip. We don't know the answer yet. A plain film of the hip joint revealed an avulsion fracture of the proximal femur indicated by the open white arrow. So here we have this open white arrow. Here some fracture occurred. And the fractured fragment identified by the solid white arrow. So this fractured fragment over here, it came from this site to this site. There is avulsion fracture, meaning by there is some muscle attached to this point which actually tore away or teared away the part of the bone over here. Now we can see the head of the femur over here, the greater trochanter over here, and this part is the lesser trochanter. What is the muscle attached on the lesser trochanter? We have done a question on the greater trochanter. The muscle attached on the lesser trochanter is the answer iliopsoas. And we also know it is a major flexor of the hip joint, supplied by the lumbar plexus and branch of the femoral nerve as well. So which muscle is most likely detached? Here the answer is straightforward, iliopsoas. If we look at other options, option A causes adduction, not flexion, and not attached to lesser trochanter. Option C, rectus femoris, is a muscle of the quadriceps femoris, not attached over here, and it is basically at the hip. It causes flexion, but it is not attached on the lesser trochanter. Option D, biceps femoris, is a hamstring muscle on the posterior thigh. Okay. Now here's an image of the iliopsoas muscle shown over here. You can see over here, this is the iliopsoas muscle, a combined. When we say iliopsoas, now what actually happens is, this is the iliacus muscle, and the psoas muscle comes from this side. And we have also discussed earlier on that there is a nerve which lies between them in the iliopsoas groove. If you have seen my previous sessions, if not, highly advised to go through them, then you will remember that this nerve over here is which nerve? This is the femoral nerve. This is the femoral nerve, runs in the iliopsoas groove. And you can see this iliopsoas tendon then comes down and inserts where? Inserts into the lesser trochanter of the femur. This is an important question to remember it, right? Okay, now here is the you can say the femur and the surrounding areas, the lower hip bone part also, and here you can see these attachments. Just go through it once, take a screenshot if you wish to, go through it once, at least revise the attachments, main attachments at least. Main attachments, if I may like to highlight over here, look at the gluteus minimus, iliopsoas is asked normally, right? Then you have the muscles over here, the adductor muscles on the pubis bone or the inferior ramus of pubis, they are attached, right? Then on the ischial tuberosity we have biceps femoris, semimembranosus. On the ischial tuberosity they are the hamstring muscles. As you go down, you also see over here the sartorius gracilis, and there is one more muscle over here, that is semitendinosus. They form the anserine, pes and serinus. What are they known as? Pes and serinus. Okay, so remember a few muscles over here at least. One more question. After spending 2 days moving a heavy furniture out of her house, this is probably the last question, all the best. After spending 2 days moving heavy furniture out of her house, a 56-year-old lady goes to an emergency room in acute pain. The patient reports nausea, vomiting, and severe abdominal pain. On examination, the doctor discovers a painful globular mass located inferior and lateral to the pubic tubercle. Where inferior and lateral to the pubic tubercle, given a presentation and history, what is the most likely diagnosis? So, after spending 2 days moving a heavy furniture out of her, so it's a lady, 56-year-old lady, and she has done some heavy work over here. She reports nausea, vomiting, and abdominal pain. Then there is also a painful globular mass. There is some swelling located inferior and lateral to pubic tubercle. Now understand over here that we have pubic symphysis, pubic crest, and at the lateral end of pubic crest we have the pubic tubercle, where, if you remember, the inguinal ligament also comes and attaches over here. This is the pubic tubercle on this side, where the inguinal ligament comes and attaches. So this site over here, this is the PT, pubic tubercle. They are saying they have seen a globular mass inferior and lateral to pubic tubercle over here. This is the site. Take any site of bilateral, let us assume. Now, lady doing intensive hard labor over here, hard work over here, moving the furniture, she presents with this particular finding. Is this an indirect inguinal hernia? It can be, but the location is different. Indirect inguinal hernia actually comes from the inguinal canal. This will be the site of indirect inguinal hernia. So location wise, you can rule this out. Is it direct inguinal hernia? Now see, the direct inguinal hernia comes through the Hasselbeck's triangle directly. Is it a femoral? Yes, it is actually the femoral hernia that is coming through the femoral canal. We have just seen that in the femoral triangle we have NAVENL, empty space. This is the femoral canal area. On this side also we can write nerve, artery, vein, empty space having a lymph node. This is the area that is actually what? It is the femoral canal, a site for femoral hernia, which is more common in females because of wider pelvis. This is the site for femoral canal, and it is a case of femoral hernia. Here in this image we can see the location of femoral hernia, the location of this inguinal hernias in relation to this green dot over here, that is referring to the pubic tubercle. Very important clinical finding. So guys, that's all. I hope you enjoyed our first week session over here. Also, do write in the comment box what else changes you need, if you need any. Also, I am thinking to start a live session over here if you are comfortable with it. The timing would remain the same, around 8 p.m. only. Do let me know. The next topic, which in the coming week from Monday to Friday we are coming up, is the neuroanatomy. If I get a time in between going live, I would love to do that. Write in the comment box if you want. Any queries, now do revise it. I am sure that all of you who are sincere over here must have revised these questions and the topics. And any queries you have, the comment box is open. That's all from my side. Thank you for your time. See you soon. Bye-bye.